Super. Are we recording? I believe we are. Yes.
Yes.
I see the red recording button. So welcome to everybody. We've been having great conversations the past few weeks talking about
Mark, you're muted.
I'm talking to myself. I thought I was doing such a great introduction there. So I'll try this again. So welcome to everybody. We've had some great discussions the past few weeks on all the changes and what's been coming around as a result of this pandemic across the world. And we thought this time we're going to have a little different perspective. We're going to have as we're titling this talk, it's about the truths and myths working in the ICU and with COVID. And so the best people to do that is we have a couple medical personnel with us. We have Mel Basu and Steve Parks. I'd like to welcome them. And why don't we start? We'll let Mel start first. And we got some interesting perspectives because not only do we have different types of providers, different parts of the world, and we can get some perspectives of what's going on in some parts of the world compared to others. So Mel, would you like, welcome Mel. Where are you from? And we have to unmute you now so you don't talk like I did to yourself. So welcome.
Hey. Hi. So I'm coming to you from London in UK. And I am, can you hear me?
Yes.
Okay. And I am actually a consultant anesthetist, or I think that would be equivalent of being a staff anesthesiologist in America. So what I'm actually doing currently is because of obviously the global pandemic and what's happened in our hospitals in London, I'm actually currently working in the intensive care as an intensive care doctor, although that's not my specialty by trade. I've had to dramatically step out of my comfort zone and work intensive care. So currently what I'm doing in my shifts is I'm basically looking after ventilated patients in ICU setting, and they're all basically all COVID-19 patients. So that's kind of where I'm coming from.
Okay, you're right in the heart of it.
Yeah.
And Stephen, how about introduction from you?
Yeah, my name's Stephen Parks. I'm an emergency room doctor in Chicago, in the Chicagoland area. I work at a couple places in a suburban hospital outside of the city. So we're not quite in the middle of the busiest place. And I also work, even a little more so these days, in a rural hospital. So I can kind of see the spectrum from rural to suburban with friends at the academic centers in the heart of Chicago. So I can speak to all of those. I also coach physicians now and have some directorship experience. So having gone to business school and doing public health training, I have I think kind of a unique perspective in addition to just the front lines as well. So it's obviously a complex situation and it's difficult for the professionals to figure out. So the more heads we can get to put these ideas together, the better and more productive conversations we can have.
Thank you. So well, let's pose sort of the similar questions to both you and Mel, and y'all take your turns answering. So as we're learning about the front lines, how about from the patient's perspective? What are you seeing clinically in the patients that may be different? You know, I hear different people trying to compare this to SARS or to some of the other, or to just getting the flu. What are you guys seeing from the patients from a clinical perspective that's different from people that you're seeing now, that have the COVID-19?
Sure. So the first thing that I would say is, obviously I'm going to be giving you a somewhat skewed picture of what's happening, because by very nature I'm working in the intensive care. So I'm seeing the very sickest ones, the ones when I'm being called in, it's to intubate them and put them on ventilators. So I can't actually speak for what's happening when they attend the ER or when they're sitting on the wards, except from when I'm called to say they're now at the point where they're not coping and we need to put them on a ventilator. So I'm actually seeing the very sickest ones. And even then, to me, it's a very unusual picture that I'm seeing with a lot of these patients, because these patients, often when you get patients that have respiratory distress, they're often gasping for breath and they're begging you to help them with their breathing because they can't breathe. And a lot of the patients I'm seeing actually don't look that bad. So their numbers are terrible when you look at what's happening with the oxygenation in their blood, what's happening with their respiratory rate and all those sorts of things. But actually looking at them, they don't look that bad. And I can I think the easiest way to explain it would be the very first COVID patient I had to intubate. I went to see him on the ward and he looked absolutely fine. He was breathing slightly fast and the oxygen levels in his blood were clearly low based on the monitoring, but he looked absolutely fine. And when I said to him, look, we need to put a breathing tube down, you're getting very tired and you're struggling. And he was like, oh, okay, that's fine, but I have some urgent work emails I need to send in a couple of days. And I said to him, oh, well, you might not be feeling well enough to send those work emails in a couple of days. And he said, well, what about in 3 days' time? And I was like, at that point, I was starting to register that some of them have no idea how sick they are. And in fact, some of them don't even feel that sick. So it's very unlike anything I've experienced before in terms of that's not typical. And there's a spectrum. So there are some that are genuinely still gasping for breath. They're the ones that tend to get sick very quickly. But there are some that kind of have this very gradual decline to the point that they don't notice it. And then they suddenly get. So some are in hospital for a week where we're just watching them and we're seeing the number, them declining, but we're just holding on in the off chance that they won't end up on a ventilator. And some actually go down in a matter of hours. So it just varies. It's not a clear picture, but it is quite a diverse picture.
And you're dealing with the intensive care. What are the averages? And we're hearing different averages. And what are the averages of? Obviously, the crux here is, do people get better or do people pass? What are the averages it takes for someone to get through this? So
we have been publishing. We have data that's collected in the UK. It's called ICNARC, and basically it does publish the data. Now, it's a range because the issue that happens is we can tell you what percentage that are coming in that are dying and what percentage are getting out of intensive care. However, there's still a percentage that are still in intensive care, still on ventilators, and we don't know whether they're going to survive or not survive. So so it's very much a range. So the range of death for intensive care can be anywhere between 20% and 50%. So if all the patients currently in the intensive care all die, then the death rate is 50%. If all of them live, then the death rate is 20%, and we just don't know. So all I can say to you is the range is somewhere between 20 and 50%. So potentially it could be a 50-50 chance that you live if you get onto a ventilator, that you'll actually make it out of intensive care.
So that 20 to 50% is if you're on a ventilator.
Yes.
And about how long, do you have an average of how long that is? So what's the average length of time that somebody passes away, that somebody dies? Is it a week, 2 weeks? I've heard pretty quick.
The ones that live tend to be on a ventilator anywhere between 7 to 10 days. Okay. Some decline very quickly on a ventilator and they barely make it sort of 2 or 3 days. So the range, I think the quickest we've turned someone around is they've been on a ventilator for 2 days and then we've managed to get the breathing tube out and they've managed to go to the ward. But the average is much longer than that, 7 to 10 days. So they've got to remember that means that there's 7 to 10 days that someone's on a ventilator, that now if someone else is coming into hospital at that point, that ventilator is now occupied. So that's where the sort of finite resource comes in with the number of ventilators. So I know there's a lot of discussion about ventilators, but what I would say is that in my experience isn't actually the limiting factor. The limiting factor is actually staffing. It's having the people that actually know how to work the ventilators, and actually that's more of an issue anyway in the NHS than actually the number of ventilators.
Thank you. And so Steve, what's your perspective on this? Stephen?
Yeah, I support everything that Mel has said from, while I'm not working in the ICU directly, obviously I'm in the emergency department, but I just got off the phone 2 days ago with an ICU physician. I can say that he's at Loyola University Medical Center, which is a big hospital, and he's seen around 2 to 3 times the normal numbers of people on ventilators, and it's all COVID patients. So, and as Mel pointed out, it's a skewed population because you're going to see the sickest of the sick. And I also personally, what I've been seeing much more of is kind of the other end of the spectrum, which are people who come to the emergency department concerned that they might have the COVID. And the challenge has been that we just haven't had the testing to give them the assurance to say, hey, your test is negative on this. And we also, even if we have the test, although this last few days now, we're starting to have enough tests that we can test more people. Even with the test, there's some uncertainty about the test as far as how accurate it is, how sensitive it is. So there's always some uncertainty. What I have seen on the people that we have tested, the vast majority of people that I've personally seen are able to go home because they're not that ICU requiring sick or not requiring to be admitted to the hospital, which is a nice contrast. And as we all experience, we have our own experience of what reality is. So Mel's reality is absolutely real. My reality of sending most patients with COVID home is also real. And how do you bridge that spectrum of realities and communicate it effectively to the public? That's been the challenge I've seen amongst physicians, let alone healthcare leaders and professionals across the board. So this one thing I wanted to throw out there is there are multiple realities to this situation, and it's so easy in the gut reaction when we're in fear is to point and say, oh, that person's wrong, or this is wrong, or that piece of information is wrong. It may be that there's levels of truth to this. And so planting that seed of open-mindedness to what we're hearing and experiencing, I think is key. So yeah, my experience has been almost everyone's gone home, but we have had a couple people be intubated from my personal small ER. And at the suburban hospital, I can speak to those numbers. We've had a total of 66 people admitted to the hospital with COVID-19, and 24 have been on ventilators. I think the number was 12 or 13 are off and are going home, and 6 have died of those numbers. So it gives you kind of the spectrum that there's definitely a range. And from what I'm hearing from you, Mel, it's pretty consistent, actually.
I mean, the one thing I would say is this isn't a fair disease. So it's not hitting everywhere in the same way. So even within the UK, London is disproportionately being hit really, really hard. London and the south of England. I have friends that work in the north of England and in Wales, where they're actually not doing very much. They're actually they've cleared out the hospitals in preparation for this big pandemic, massive rush of patients. And they're all sitting twiddling their thumbs, not knowing if it's actually just not happening or it's never going to happen. And so they're hearing all about the horrendous things that are happening for us, and it's just not happening for them. So it's just not fair. So that then skews it, that if you're in that area of England where it's really not, like all you're suffering is the economic side effects, but not the health side effects, then you're kind of wondering what the big fuss is about. Whereas I think, I mean, I know personally amongst my friends, all my friends know at least one person who's been infected, who's had it happen. I, for example, today just heard about one of the doctors in my hospital has just died from COVID-19. So it's a very different reality for me to even people in the north of England or the east of England. So I can only imagine that, so I can't necessarily generalize to what's happening in America, but I'm almost certain there are patches of you that are going to be hit really badly, and the places which will hardly experience anything. And then they'll be wondering, what's the fuss about? So it just varies. Not fair.
Back to what Stephen was saying on we all have our own realities and what we're seeing, I guess, and they're all our own truths.
Yeah, I want to answer something that was pointed out. I think Felix, you brought this up, but there's theories on why this is and what exactly is going on under here. One of the big thoughts is population density. You know, obviously, if you're in a really dense population area like New York, like where you're at, Mel, that you're skewed to the exponential curve. The way that this launches and it spreads is going to be much more unpredictable, and it's going to spread more quickly. That said, that's not the only key to this story. There's other layers and factors that are being investigated, because you have dense areas on the West Coast that simply aren't hit as well. The one trend that's been consistent though is the further you get from the city centers, the less infected per population even. So that's fairly clear at this point, which is why I think they're talking about opening up certain areas, at least in the U.S., based on what their numbers are, because it's not the same, like you said.
Mm. And it is disproportionately hitting Black and Asian sort of minority populations, and we've had a lot of discussion about in the UK about why that is. And one argument is that because they're more likely to be in the service professions, they're more likely to be working in healthcare, working in the grocery stores, working in, transport centers, that driving the buses and all that. So that could be why they're being exposed more to the disease, or actually there may be some underlying reason that they've got predisposing medical conditions or something that makes them more likely. But what we do know is it's hitting men much harder than women. The men are dying, and we don't know why that is, why it's the men. We know, obviously, if you're older, you're more likely to die. You're more likely to have pre-existing condition. But what I want to say to that is your pre-existing condition doesn't have to be a severe condition. So it can be mild asthma. It can be just blood pressure that's controlled on tablets. And that's classified as a pre-existing condition that could lead you to die. But normally that condition wouldn't kill you. So you've got to be there's lots of complicated factors, but it's not, as I just keep saying, it's not a fair disease. It's hitting some people really hard, and then some people are getting off quite lightly.
Are you following what's the curve like where, everyone talks about the curve? Do you, in London there, are you guys past the crux where you've hit the biggest part, or do you think you're still good, you're still on the incline, or?
Well, there's so much uncertainty. We don't really know. I mean, there is an element that we're making this up as we go along. There's a lot of learning on the job because we this is a new disease. We, at the moment, are plateauing. So we've had sort of very, in London in particular, we've now started to, so we haven't dropped off necessarily, but we've stabilized. So everyone kind of goes, oh, well, we've plateaued. That's all right. Good for us. Worst is behind us. But what I will say to that is we haven't plateaued at a great level. We've plateaued at a level where we're still very stretched in our healthcare. It's just reassuring that we're not now exponentially growing as we were. I mean, we all learn about compounding and how compounding can be great for your finances. Well, it turns out compounding isn't great when it's a disease spreading. So the numbers obviously stayed quite flat for quite a long time, and then they rapidly took off. And our numbers of infected were doubling every 3 days. Now it's calmed down and it's looking like we're sort of stabilized, but we're stabilized at about a number of 700 to 800 people dying per day, which is not a great level to stabilize at, but thankfully it's not climbing as rapidly as it was.
Wow.
So we don't know if there's going to be a second wave. We don't know if it's going to take off again. There's a lot of uncertainty.
And what about Chicago? You don't hear Chicago in the news a lot, Stephen. I know, we hear New York and even LA and Detroit. Michigan got hit really hard, probably even harder than New York. They just don't have the population to make the news. But I don't hear Chicago in the news very much. What's going on?
It's really, like you said, New York, Detroit, New Orleans are the ones that have come to mind because they were unexpectedly hit harder. Chicago has, I can give first-hand experience of we prepared for the worst, and the tsunami hasn't really hit. Why that is going to take time to go back and look at that. I can tell you, we went and they spent $25 million to set up a makeshift hospital at a place called the McCormick Center, the biggest convention center in the city. And they basically haven't had to use it because a lot of ERs are experiencing what I've been experiencing as you go in for a shift. And normally at a hospital where we might see 170 to 200 patients per day, we're seeing 50 patients per day. It's because people with other problems are not coming to the emergency department.
Stephen, do you think also, it's Allison, I was just wondering, I know that, I used to live in Chicago and I still follow things there. One of the things that I've noticed and my friends keep talking about is the mayor there has been like really harsh in terms of really shutting things down. She's been seemingly more aggressive perhaps based upon maybe what she's seen in New York or whatever, and has been very aggressive about shutting things down. I wonder if that contributes to it as all.
It's certainly possible. What I've seen is we haven't been as harsh as, say, like Michigan next door. That said, it's been a general lockdown and distancing procedures, but it hasn't been as strict as some other states. So I'm sure it's part of the factor is how well people are adhering to the distancing guidelines and how seriously people are taking the disease, because social distancing has a visible component as far as what you see and people anecdotally are going outside and doing. And there's also the seriousness of how people are taking it and visiting or not visiting family members and things that are, I'll just say, behind closed doors social distancing. And my suspicion, I have no data to back this off of, but my suspicion is that what I've seen here versus anecdotes I've seen in other parts of the country is there's a focus of concern here that has pushed people to really social distance a little bit more. So hopefully that's a helpful insight for you, Allison.
It's a good question for you here on.
I was just going to say.
Yeah.
I was just going to say, we've definitely seen the same thing that Stephen's seen, and in fact, a lot of the hospitals in the UK have seen the same thing, where in our A&E departments, which is the equivalent of the ER, we've actually been seeing less patients. The ERs are less busy than we would expect. And I mean, the problem is the ones that are coming in are the very sick COVID patients, but we're not seeing the heart attacks, we're not seeing the strokes, we're not seeing the people with the ruptured appendix. And we're wondering, where are all those patients? And are they all sitting at home suffering heart attacks and not coming in because they're so terrified of getting COVID? So we're mystified, and we keep waiting for them to come in, and to come in a lot later and sicker than they would have done normally. So there is a mystery going on about where are all these patients.
We were looking at a statistic here in Texas, and goes to the same thing. It's not, who knows how things are, why they're playing out the way they're playing out. You go to New Orleans, it's hit very hard. The biggest city we have in Texas is Houston. Houston has 0 deaths. We have deaths in Austin and Dallas and Fort Worth, but you take our biggest city in Texas, and they have COVID, but they don't have any deaths, at this stage. So it's quite interesting.
It will definitely be interesting to see, looking back 3 months, what the overall mortality rates come to be.
Right.
There's something called influenza-like illness, where you suspect someone has flu, regular influenza flu, but you don't run the test, and generally that's documented and diagnosed as influenza-like illness. Those numbers have decreased dramatically this season compared to other seasons, along with other things like you mentioned, Mel, appendicitis and heart attacks. We'll see what's happening with those numbers, but across the board they've been down over in the U.S. as well. Why? We'll have to investigate into that, but we don't know. It's definitely a trend.
There's an interesting question for you guys. Have you seen anything with pregnancy, with women that are pregnant? Are we seeing any issue for them? Does that count as a pre-existing? Does it make them weaker if someone comes up with COVID? Are we seeing anything where the virus passes to the infant?
So we've definitely seen pregnant women with COVID, but we haven't seen any increased frequency compared to the normal population. So I'm saying that we're getting patients coming in who are pregnant, in labor, delivering, who've got COVID, but they just seem to be the same numbers as you would have got. Now pregnancy is supposed to suppress your immune system. So we saw it quite clearly when we had swine flu. Swine flu used to hit pregnant women harder than anybody else. That we can't say for certain is happening with COVID. Now, I have seen in my hospital, we did have someone who had a newborn who was 5 hours old, and that newborn got COVID. Now, what we're not sure about is, can it be passed in utero, or is it actually passed on at delivery? And that we don't know about. And it was very quick for the child to have developed COVID. What I will say to you is these young children are far less likely to die. So although they can get quite sick, you don't seem to get the levels of death. We have had some pregnant women die, but again, those numbers aren't huge. So this disease doesn't seem to be specifically taking out pregnant women, in my experience in the UK anyway.
Okay.
That supports the data that I've seen as well. And I'll throw out, there was a study that was done where a medium to larger size OB unit, labor and delivery unit, had every single patient who came in tested for COVID just to see what the numbers would be, and so that they would segregate who does and who doesn't have COVID. They found 15 to 18% were positive, most without symptoms, and they all did very well. So it's not a big enough study to say how it affects the fetus or not. I think the general advice I can comfortably give, not diagnosing or treating, which is a disclaimer, I can't do that over Zoom, but the general advice is to consider yourself, if you do happen to be pregnant or know someone who's pregnant, to just take the precautions that are recommended and not go out into the busier places, and be extra mindful of your own immune system and health. So that's certainly helpful for everybody, but particularly if you're pregnant, especially third trimester.
So you guys are pretty involved. Let me ask you this. So have you guys gotten tested? Do you guys have the antibodies? You're exposed? Do you know, how are you staying healthy personally? What's going on in that regard?
So although there's been a lot of talk by the government of testing frontline healthcare workers, and it is coming in now-ish, it still hasn't been established in our hospitals. Having said that, I have actually been tested because I was unwell last week, and we weren't clear whether or not I had COVID. I had symptoms that weren't very typical of COVID, but COVID can present in very different ways. So that's one of the things we can say is actually, you can actually present to the hospital with diarrhea and abdominal pain, and that could actually turn out to be COVID. So everyone classically hears about the cough and fever, but in fact, some people it presents like a tonsillitis, for some people it can present like a runny nose or a headache. And for some people coming to the hospital, they were coming with diarrhea and abdominal pain, and it was turning out to be COVID. So I had very atypical symptoms, but I did have a low-grade temperature, so they tested me, and I came back negative. The only thing to say about that is in our data, you can get a 30% false negative rate. So that's kind of where we're at. So even though I came back as negative, I could still technically have had COVID because there's a 3 in 10 chance that wasn't an accurate test. I was lucky. I stayed off work for a few days. I didn't get any more symptoms. My symptoms resolved, so I went back to work. So they're definitely wanting to test frontline because they want to get people back into work as soon as possible, particularly the people that are isolating because somebody in their family has symptoms. They don't even have symptoms. So if you can test the family member and prove they're negative, then they can come back to work. So there is plans. There's no antibody test as yet. It's still just the test checking if you've got it currently.
Yeah, I can say I have not been tested personally. However, what we're seeing is if you have any symptoms whatsoever, you kind of get priority as a healthcare worker to get the test done, like you said, Mel, because you need to know pretty quickly if you're positive that you need to be not taking care of patients. That said, I've had, there was a stretch I was working quite a few ER shifts back to back where some of the first symptoms that you can get are honestly can be very similar to flu. This is another layer of truth thing. You hear out there, it's not the flu at all. Well, it's not when you're in the ICU, absolutely not. And in the beginning, it can be similar to flu. It shares some symptoms. So there were a couple days where I'd done some shifts and I had a little just irritated throat and a little runny nose. I'm going, okay, I got to take care of myself. So my regimen personally is to hydrate like crazy. It perturbs me that I'm not seeing that from our public health leadership out there. It's wash your hands so it doesn't get us. And where's the hydration? The hydration is absolutely critical. When you're not hydrated, you're not making enough mucus to expel the viral particles. You're not having enough hydration of your cells to have the correct functioning. I'll just leave it at that. And so I'm hydrating pretty aggressively. I usually drink 60 ounces per shift. I've been upping it to about 90 ounces. And there's, in my opinion, pretty strong evidence that's scientific and in the literature supporting vitamin A, vitamin C, vitamin D. And the way I see it, it's not going to hurt as long as you're not overdoing it. You know, zinc is a good example. Zinc can be helpful to boost your immune system in the right dose, but it's not something that you want to go take 3 times the dose. I have had some patients come in and say, hey, look at me, doc, I took 3 bottles of vitamin C. I mean, it's probably not a smart thing to do, to overdo things. There are definitely some things that will protect and bolster your immune system. Number 1 and 2, hydration and rest. Mel and I, we were talking a little bit before this call. It's, especially us as healthcare workers, this is a time where we're called to do what we were called to do, and to do it more because we're needed more than ever. And one of the biggest lessons I learned harshly at one point in my life was to learn to say no, not because I'm selfish and I'm weak, but to learn to say no because I have to keep myself functioning at a high level and resting at a high level effectively in order to continue to help. So that's been my main message to my docs at both of my hospitals is rest effectively. When you're going home, don't get sucked into the Facebook vortex of stress because it's not helping you. You're more likely to get sick. So that's been a big part of my plan is mitigating and limiting how much media I'm consuming, being very intentional about that as well. So hopefully that's helpful for people.
Yeah, so what I do is, because what happens to me is I wake up every day and I wake up with some sort of symptom, some vague symptom that I think could be COVID. And because I am exposed to such high levels of the disease where I'm working, I'm amazed if I haven't got it yet, to be honest. And most of my department, we've got 4 off currently, all COVID positive, one of them quite sick. So like it's just inevitable. I always think it's a matter of time. So I wake up every day and go, this is it, because I feel terrible when I wake up and I'm like, this is it, the COVID's finally got me. I've got some tickle in the throat. I feel really dry, slight headache, feel really exhausted. So I then hydrate, I take my vitamins, I take vitamin C. And then if I think I've got the symptoms, I'm just telling you, this is what I've been doing to keep an eye is, I'm normally very healthy, so I didn't have any of this stuff beforehand, but I bought a thermometer because I have to decide whether or not I'm safe to go to work. The last thing I want to do is infect any of my colleagues or any patients that don't have COVID. So I have a thermometer, I monitor my temperature. And the other thing I bought is a pulse oximeter. So I don't know if you've seen one of these. It basically monitors the oxygen levels in your blood. I bought it on Amazon. I'm not selling it, I don't have shares. But what it basically does is because I am asthmatic, so I know that if I get COVID seriously, my lungs are already an area of weakness. And one of the main symptoms is getting inadequate oxygen levels in your blood. So this monitors my oxygen levels. It might be upside down, hang on. Yeah, so that tells me my heart rate and my oxygen levels, my pulse ox as it's called. And basically a normal person should have SATs of above 94%. That's pretty bad. That's if you're a smoker. But, I'd be aiming for 99, 100%. So that's my kind of way of just checking, am I sick enough that I would need to go to hospital? If the oxygen levels are dropping from where my normal levels are, then that would be a concern for me to actually get medical help. So I don't know if that's useful to anybody who's been wondering about how do you know how sick you are.
Mel, can you tell us what that's called again, that little device?
It's a pulse oximeter.
Pulse oximeter.
Yeah. So PULSEOXIMETER. I think it's about $30. It might be more now, but it was about $30. And it's just how I decide, do I need to seek extra medical help or am I sick enough that I shouldn't go to work?
Let me ask you guys, so we're talking about vitamins and stuff, and we've got some vitamin questions, but then I have something. One of my doctor clients is using vitamin C a lot in IV. Like I said, it's getting very prevalent now with using the IVs and the ICU of vitamin C. And then and then he said it's just starting to become mainstream here in the US. He said it started in Europe and in China, and it's becoming more mainstream in the hospitals to get the IVs of the vitamin C, and then worked it to while patients were in the ICU, and then they worked it to as people were starting to get symptoms, and he saw that they were healing quicker. And now he made the news last night because I think they're booking like 500 appointments a day out of their Detroit offices, and Detroit's so heavy, and they're basically doing IV vitamin C for frontline, for basically anybody that's an essential worker. Are you guys seeing a use of vitamin C IV at all in your settings? Are you reading anything about that?
So we're not using IV vitamin C. I do know that they used it quite a lot in China, and I heard that they thought it was effective. The problem is I've not seen the data or the evidence to back that up. And so the tricky thing is with all of these treatments is the lowest form of evidence is something called anecdotal evidence. And that's evidence where one person's used it and they've had an amazing result. And the problem is we don't know if that one person is someone that would have got better anyway, whether they'd had vitamin C or not. And it's only when you see significant results among a big number of people that you can say, oh, this is definitely something that will help everybody or will improve it. So, and we just haven't had the time. This is a new disease. It hit quite quickly. So to get that level of data, and I know that people have used vitamin C in the past with other conditions, and I'm not against it, but I don't have the evidence and we don't use it as a routine in the UK.
You seen it, Stephen? Thank you.
Yeah, I back up everything that Mel just said. I've seen the reports that it has been used in China, but I haven't seen the big studies at all. And while that certainly is what sways common and standardized medical practice, this just brings up something that I probably don't need to go all the way into the rabbit hole on this, but yes, there's massive funding of things like antivirals right now that are actually occurring and have major financial backing. But the financial backing for a big vitamin C study is frankly lacking. And this has to do with the incentivized structure in our medical system. So it brings a really important point that I think runs to the core vein of our system and how we practice. We can only as physicians practice based on the strong evidence. In order to have that evidence, you have to have the studies being done. So right now, the studies that I've seen on vitamin C are pretty darn small, 10 to 30 patients. And it's just not strong enough to one, have the power to show a strong statistical significance to change practice on a large level yet. So, but I love that people are interested and are asking about it because we need to be looking there.
From my understanding, and I want to find the resource for you guys. From my understanding, actually, a paper is being published in one of the journals in November talking about using vitamin C IV, and it's supposedly fairly strong and supposedly a standard sort of medical sort of paper how you guys are used to seeing them. So, yeah, but anyhow, do you guys have any? Because a lot of people are asking, and I know I hear what I get from some of my physician clients. But do you guys have recommendations for like the vitamin C's and D's and zinc and any of that stuff if people want to keep their immune system? Obviously, Stephen, you talked about just the basics and hydration and rest, and then keeping our bodies healthy that way. Do you have recommendations for these other amounts?
Yeah, can I? A couple things. I coach a couple physicians. One has done her fellowship in naturopathic medicine, and she also has a pretty nice and long and well-backed sheet of data-backed recommendations specific to COVID-19. And so I've been using that and investigated all the sources on that. So some of them I've already kind of hit on, which is the hydration and the sleep. Like that's huge, and psychological stress management. Like I can't speak how strongly and how important those are. As far as specific recommendations otherwise, zinc is one of those that I mentioned. If people are taking notes during this, typical dose per day is 15 to 30 milligrams. A lot of multivitamins may have some zinc. So I would not go farther or higher than 30 milligrams at the most. The way I've been personally using it is on days where I work in the ER, I'll take 30 milligrams. On days that I'm not working in the ER, I do not take it. So vegetables, fruits, flavonoids, basically those are helpful to our body's immune response. So we're not overreacting in our inflammatory cascades. What I typically just generally suggest to my patients who come in kind of what we call the worried well, and people who are concerned, who are not positive for COVID or who are not sick enough to be hospitalized, I frankly just give them the alkaline acid food chart that you can find off of Google image search. Perhaps in this call, the level of awareness is higher than most, but a simple one-page sheet that shows not that things are good or bad, but what's the spectrum and where is this particular food or beverage on the spectrum of acidity or health. So I'm just dumbfounded still every day by the people who come in, just their diet is Mountain Dew and Red Bulls. And that's 3/4 of their calories. So, so that's a big thing. Vitamin C, typical dosing there is 500 to 3,000 milligrams daily. Some of the studies have shown you can go even higher if you have an acute infection right in there. But as far as preventative, 500 to 3,000 milligrams. Melatonin has some benefits. We all kind of associate that with sleep and rest. So 0.3 milligrams up to 20 milligrams, but generally on the lower end of that can be helpful. And then I mentioned vitamin D. It depends on the vitamin D that you're using, so I don't want to give exact milligrams for that. And the last thing is elderberry is a phenomenal natural option. There's been some discussion in the doctor and physician forums. What we're seeing with COVID-19 is it's not necessarily the virus itself that is causing morbidity, mortality, and death. It's the response of the immune system that's an overreaction to that. So one of the concerns with elderberry is because it increases a particular inflammation component called interleukin. I won't get too technical on it, but the concern was, oh, don't take elderberry, it's going to make you worse. And so the caution with elderberry is if you start getting sick, maybe back off of it as a precaution. But as a preventative, all the data I'm seeing is still supportive of that. So I'll leave it at that. If anyone would like, I'd be happy if there's a way to distribute this, to forward the document to people on the call. So we can see if that's able to happen. I'm happy to do that.
Then we can post it in the group there where we posted this. What about, have you heard anything on nitrous oxide? Have you seen use for that?
Nitrous oxide is not something we would. Are you talking about nitric oxide?
Nitrous, the little tablets you take to see what your nitrous oxide level is, and was told this by a physician.
So, I mean, for some ventilated patients, we do use nitric oxide, but nitric oxide is different to nitrous oxide. Nitrous oxide is laughing gas. You know, the stuff that you use in the dental.
Right. What's the NEO or what? There's a brand for it that you buy. And I know, what is it?
And as far as I know, with nitric oxide, it's a gas and it can only be delivered as a gas. So I don't know about any tablets per se that could be useful. What I will say is, in addition to that, because this primarily hits your respiratory system, your breathing, any sort of anybody that practices sort of deep breathing exercises, diaphragmatic breathing, things where you're increasing your lung capacity, all of that is very beneficial should you then should this virus hit your lungs, basically. The more lung capacity you have, the better. And what we find is most people tend to have quite small lung capacities because they breathe very shallowly. So people that do diaphragmatic breathing, yogic breathing, all of that stuff, I think is very beneficial to increase your lung capacities as a baseline.
Okay.
I've got to add to that too, the breathing exercises have invariably been shown to strengthen your parasympathetic, your rest digest immune system, which is key in this time of uncertainty. You know, everything is uncertain in the world, we think, in our nervous system, and taking 2 to 3 minutes to do a deep diaphragmatic breathing process. And there's many different ones. I prefer the box breathing, is what I teach to my patients. Extremely simple. You can Google it, find it. Mark Devine, many in this group, you know, may have learned it from him when he came and presented at leadership. But it will, in a few breaths, calm the nervous system. And we're so charged when we go through the fear consumption of sensory inputs lately that we've got to find ways to diffuse that. And the beautiful thing about it is it doesn't only diffuse it in the moment, it trains our nervous system, just like we're building a muscle in the gym, it trains our nervous system to be able to relax more effectively, more efficiently in the future. So go deep breathing.
That makes a lot of sense. Great advice. Let's, you know, we started this, especially because of where you guys are working, you especially Mel, right in the intensive care with people at the critical stages of their life. Let's start at the big picture. I think everyone's perceived this as COVID-19 is almost a death sentence, and everyone's looking at it as, oh my God, do I have it? And am I going to die? And let me ask you your opinion on this. I'm basically getting, everything I'm saying is we're all getting exposed to it anyhow. you know, so this belief that somehow I can hide and, you know, stay 6 feet away from everybody, and I'm never going to be exposed to COVID-19, from my understanding, is just false. I'm either going to, and odds are, and I'm going to get exposed sooner or later if I haven't been already. And odds are I might not get any symptoms. It might be a symptom, and then I might. And as I go down that path, I might get sick and have some minor symptoms, and then I could go down the full path and getting sick. But from the, you know, I appreciate your comments or your insight into that. I mean, this isn't anything in my mind. This isn't anything to. We don't want to embrace it. At the same time, it's nothing we can hide from. I guess is what I'm saying. And
True.
it's not going to kill us all.
No, the truth is, I mean, and that's the thing. If you're getting the big picture perspective and the big picture numbers, then absolutely. I mean, I think unless a vaccine develops very quickly and very soon, we will probably all be exposed to COVID-19 and get it in some form. And 80% of you will have either no symptoms or very mild symptoms. So the majority of you will be absolutely fine. The issue is that 20% of you will end up having what we would consider severe symptoms that potentially will need going to hospital. Of that, 5% of you may need to go to intensive care and critical care. And that's potentially where you're starting to look at, could this kill you? So the issue is we don't know who those 20% are. So it's, are you a gambling person? What do you think the odds are that you're going to be one of the ones that gets it severely? And we do know some young people are getting it and dying. It's just that numbers are much smaller, and you're more likely to be an asymptomatic carrier the younger you are. So absolutely, to keep it in perspective, I know if I get it, I mean, obviously I've got asthma, which potentially puts me in a slightly high risk category, but 80% chance I'm going to be absolutely fine. And I'm almost expecting to get it at some point. The issue really is about timing. You do not want to be getting this at the same time as everybody else. Because if you do end up being in the 20% or the 5% that need hospitalization or critical care, if there's no hospital bed and no critical care bed for you, then you're far more likely, that's when people are going to die that wouldn't have died otherwise. The more you spread it out, the more likely you're to have the resources available should you then need it. So if everyone gets sick at the same time, then there's going to be a whole lot of people that will die because there aren't the resources to care for them. If you spread it out, which is a much worse economic issue for people, then actually there'll be nurses, there'll be doctors, there'll be ventilators, there'll be hospital beds for you to go into should you be unlucky enough to be one of the ones that gets really sick. Does that make sense?
Very much so.
Hey, Stephen and Mel, are you saying people that have had it and then they got it again, or are you absolutely immune after you had it once?
My understanding on that is we just don't know. There's been some anecdotal reports of people who have gotten it twice, but we just don't have the antibody testing yet to get an idea of, okay, who has an antibody and then later gets it again clinically. So what have you seen, Mel?
Yeah, so I can tell you that we've as yet, I mean, we're still in the first round, so we've not seen anyone, and those people are only just now getting out of hospital. So we've not seen anyone come back yet who's had it before. And there's no idea, there's been no suggestion yet that if you do get it again, do you get it as severely as the first time round? We don't know that. So all the information about reinfection is coming out of Korea and some out of China. And what we're not sure about is, are they being infected by a different strain? Because there are different strains of this virus. It started to mutate into different strains. And I know there's at least 4 different strains in China. So are they then getting infected by a slightly different strain than the strain that they had before? Or there is some suggestion that actually, is it reactivating? You know how, have you ever heard of shingles? Do you have shingles? So you can get chicken pox, and then subsequent reactivations of chicken pox are called shingles. So is it something like that, where actually you've got it now sitting silently in your body, and then something can trigger a reactivation, and we just don't know yet. But personally, I've not seen anybody come back yet, because we're still only dealing with the first round of it. We haven't had it long enough yet.
Thank you.
Yeah, I want to, if that's okay, Mark, circle back to what we were talking about as far as the, morbidity numbers and prevalence. Prevalence is something as far as how many people in a population have it at one time. And this gets down to the core issue of testing. And we may have read about this, but I just want to reiterate the fact that we have very little idea how many people who are not sick in home and haven't gotten tested have actually been exposed to this virus. There's 2 articles that I'll just bring up. One out of Santa Clara County out of California, where they just tested 3,300 people, and another one out of Boston where they just tested 500 people in a homeless shelter. And what they're finding is many more people have had COVID-19 exposure than what was realized. In the homeless shelter, was out of 397 people, 146 were positive, which at first part of the response could be, oh man, that sounds really bad that they got it. But 146 people were fine and not sick enough to even go get checked out at the hospital. The upside to that data potentially is if you've got 3 to 5% of the population, which is what these are suggesting, that have been exposed to COVID, have had it, and have no idea that they've had it, that is a dramatic shift to the denominator of mortality data. So if you've got, I'll use US numbers because I'm a little more familiar with them, 30, as of this morning, 36,000 deaths and about 700,000 people tested. If you had tested, let's say 10 million people, if you had an extra 400,000 people test positive but weren't sick and obviously not dying, then that changes the mortality rate dramatically lower. So just if everything that I've looked at with the models, what I frankly and honestly expect, we won't know till time tells us, is the mortality rate is going to continue to go down. It doesn't take away from the danger of this disease or the fact that people end up in the hospital. Mel, you hit it on the head, and I agree that the concern is the curve peaking with too many getting sick too fast overwhelms the ICUs and overwhelms our ventilators. But it's actually a good thing if more people have had this, because it means that overall the virus is not as deadly as what we first anticipated. So I think, as with anything, the more time that goes by and the more data we get, the more we're going to continue to understand this better. And frankly, the less fear we can all have over this.
And do we believe that that's like everyone talks about, we're the summertime, it was likely to slow down anyhow naturally, and then those people then that haven't been exposed as part of the whole keeping the curve down, those people then haven't been exposed, will be another uptick in the fall. We don't have real evidence, I guess, but that's sort of the belief.
I think as you can see with the modeling, there's a lot of guesswork. So there's a lot of uncertainty, and we're trying to give people certainty when we don't really understand this disease yet. So my feeling is I don't understand why that would be the case when actually we've got cases in Iran, we've got cases in the Far East, which has quite a temperate climate. We've had cases in Australia, which is their summer. I don't see the seasonal aspect. I don't think it's like the flu, where, flu is very much a winter disease, and you get your sort of deaths peaking in the winter, and then it sort of calms down in the summer. I'm not convinced this is the same entity and it will have the same like calming down. I think the only thing that makes the difference is the social distancing and the quarantine measures. The minute we start to mix again, it will potentially flare up again until either there's a vaccine or we've got enough people that have had it and hopefully are immune that it stops spreading.
And this is it speaks to the differences in opinion that we can have as professionals, because and maybe I'm being swayed by the fact that I'm not in super hot zone, but when I look at all the data of respiratory viruses and the epidemiological curves of previous SARS viruses, technically COVID is a SARS virus. It's an evolved SARS virus. The curves in the US all peak around basically now. And what I'll be looking at in the data from an epidemiological perspective is how do the other curves from the other common respiratory viruses potentially shift relative to what COVID is doing. And I'm not, this could have been, as much of a guess as anyone, but in early March when we were just starting our efforts, talking to the CEOs of the hospitals and the departments kind of spearheading this response, We didn't know what tidal wave was coming, but we used second week of April as a benchmark of, we need to at least make sure we have sustainable resources to get us to the second week of April, because that's what we have seen with all these other respiratory viruses. Time will tell. It's interesting. I heard Dr. Burks, one of the advisors to the U.S. leadership right now, say that we really have never done social distancing like this at scale like this. So it's almost its own experiment to do this on such a global level. But now what we're going to start having is different areas as they open up. We're going to start to see differences, and we're going to see failures if that's really the case, or maybe we won't. You could take a different angle and find data to back those angles. You could look at Sweden, and they haven't seen the same increase per population with the same restrictions. They've actually been a little more lax with their restrictions, but you can also certainly look at others who are extremely strict and had really great results because of their social distancing efforts. So this is an ongoing investigation by a lot of smart people, and the more we can have conversations from different angles, the more accurate I think we can be. I saw a post the other day about how doctors are focused on one angle, virologists are focused on another angle. We should really be putting all the decision making to the epidemiologists. Well, that'll help for the epidemiological aspect, but there are always other dimensions. And so putting all these and pulling all these together is really the challenge, and that's where constructive dialogue comes into play. So it's like having conversations like this, where we take different perspectives and really digest them. And at the end of the day, everyone can take all the data that comes at you. There's gosh knows enough of it, and make your own decisions. That's what I encourage everyone to do, is stay curious and stay open to alternate perspectives. Because Mel and I, we're professionals from what we do, but we don't know everything. Gosh only knows where we're actually headed, but we do know how to be honest in the way we communicate and what we're seeing. And hopefully that's helpful for everyone.
What are your all's, that's a lot of help. What are your all's thoughts on, and I noticed, Mel, you addressed it. From what I understand and talking to some of my physician clients, the antibody tests, one of the things people are relying on is one day we're gonna have these antibody tests to tell us that, oh great, I've already got this built and I'm never got sick, so I can go back to work and hang out and hopefully be fine. But talked to one of my clients, he bought like 20,000 tests from China, and he found out they had like a 40% false negative rate as he was testing them on, and then he had another set of tests that he's trying to rely on, and he found they had about a 20% false negative rate. Have you seen any tests out there that give really good results, or all of them still, as far as we know, still have a lot of false
so
negatives?
the test we're doing, like I said, there's a 30% false negative rate, and we know for a fact it's inaccurate because we've had patients in the critical care with all the features of COVID. The scans all look like COVID, the blood tests all look like COVID, they're behaving like COVID, and they've come back as COVID negative. And then we've done 3 tests, and then the 3rd test has come back positive. So we just keep testing till we get the result we know it's supposed to be. So, and that's the thing about when you ultimately get these numbers and you're looking at the death figures that we're getting, the death figures that are being quoted for each country, my understanding is, or at least for the UK, is for the ones that are confirmed COVID, as in they've had a test that's come back positive. But there's going to be a whole bunch of people that either died in the community or died in hospital without that positive test, but had every feature of it, and they won't necessarily be put down as a COVID death. What I will say about the antibody test when it eventually comes is there's still a lot of discussion about that. The antibody test will be saying, what it will say to you is that you have been exposed at some point to the coronavirus. Now, whether or not it means that you're immune to all the other strains of the coronavirus, we don't know. Also, how long that immunity lasts for, will that be the one that prevents you? So we don't want people to rely on this antibody test as the be-all cure, because it doesn't necessarily have all the answers. All it will tell you is whether or not you've had a version of the coronavirus previously. Have you been exposed to it before? But it doesn't necessarily mean that you can go out into the world hugging and kissing everybody and not potentially get reinfected, or that you're not currently infective and still able to pass it on to other people.
Yeah, the bottom line is we just don't know. There are antibody testing that are coming out, that's coming out now. I have I'll say a police officer of a friend who had access to that test and was surprised to find out that he was positive. And he thought back, well, it was late February where he had a flu-like illness that lasted 5 days. And so this is just the mind putting and making connections to what we really don't know is a connection or not. And I completely agree with what you said, Mel. We just don't know what that means. It just means that you were exposed, and we can't take any other data from that. So we will see. We won't know until there is a second wave of some sort with actual information on this. So time will tell.
And as far as vaccine development, it's still my understanding that just because of the way a vaccine has to be tested and all that, we're a year out. Is that are there ways to get a vaccine that you can rely on in 3 months, or is it just something that no, the vaccine is different and a different animal, and by the time you test it and make sure it's safe enough to give to the population, we're still probably a year away?
I think we're a year away. Obviously, there's extraordinary incentives to get things out more quickly. And there's been clinical trials that have already started. There's normal process that happens for regular drugs. It's already much quicker of a process for vaccines, if you look at least the US system that I can speak to. And that normal process has already been accelerated. So I gotta be careful when we're talking about vaccines. It's such a polarizing issue. And we could save that for another time. What I will say is you've gotta do appropriate testing on these things before you roll it out to the public. There is a study I specifically read the whole article on about how they were doing SARS vaccine testing, and what they found was it actually decreased the chances of getting that true SARS virus clinically, but it increased the severity of getting symptoms of the SARS virus when you got it. And the thought was that it actually triggered and primed the immune system to overreact. So you've got to do your diligence on these sorts of things, which is why I can comfortably say I don't think this is even on the radar until next spring of 2021. But you know, we will see, and I'll certainly be reading those articles.
Right.
And then there's a whole nother thing that I'm already seeing online backlashes to a vaccine that doesn't even exist yet. So I can only imagine when the vaccine is finally, the magic cure has arrived, whether or not actually it's embraced in the way that we expect is also another issue to deal with at the time.
Well, and then a vaccine, if this is creating multiple strains, as you said, if there's 4 strains in China already, and this thing creates this strain, maybe we create a vaccine for the strain that's sort of out of date, and the new model's out, and it doesn't matter anymore. So,
well, it's still the issue about. I mean, obviously, the America strain is felt to be derived mainly from the Italian strain, which was one version of the strain that came from China, and it was felt to be a more severe strain. So I think obviously this virus mutates quite slowly. So there is hope that you could get on top of it enough, and even if you get a partial immunity, that might potentially reduce the severity of the symptoms you get, but we don't know until it's tested. So it's all very unknown.
you guys have been very. Is there any? So I mean, I feel like I've learned a lot from both of you. I appreciate it. Anything that we're not addressing, you think clinically or health-wise that everybody should know that we haven't asked or you haven't had a chance to address?
I'll jump in. I think I've already kind of said this, but the focus, I think, that I've tried to bring to those in my circles have been, you'd think common sense, but it's what, I'll put it this way, you know, Navy SEALs have this thing called the circle of concern and the circle of influence. There's so much in our circle of concern right now. We can go out and be concerned about so many aspects of where this disease is going, what it's done. And also, at the end of the day, do we personally have an influence on whether the vaccine is getting developed right now or not? We don't have a lot about what we're concerned about. So we need to be really intentional about what we're concerning and spending our time on, and spreading messages of, I think, empowerment and what you can do. What you can do is take care of your immune system. What you can do is be very intentional about how you interact with other people. What you can do is be very deliberate with your communication, and how we react to other things that we read. I would love to see more of that in society, because this virus is real, and also the reactions to it are largely how we as humans react to them. And we're seeing that at a mass scale in a way, in a time that we're more connected than ever. So well, I'm honored and thankful for everyone on this call to be helping share hopefully some wisdom and some insight and some factual experiences. So my message is to be tolerant of others who don't have the same skills that everyone on this call has. Not everyone is as curious as we are, and be tolerant of people who are having a different perspective and a different experience of what they're reading, because we're all just a summation of the things that we've digested over our lifetime. So leave it at that.
Great wisdom. How about you, Mel? Anything you can think of that we haven't touched on that you think we should?
Yeah, so I mean, I think the reason I wanted to sort of be part of things like this is that in no way do I want to contribute to the panic and the anxiety and the fear that is out there. But I think the only way to really neutralize that is to give the truth. Because equally, there's a whole proportion of people that want to live in denial or have really had very little exposure to it and think it's all fake. I can tell you it's fake. And if you know me, then you know that, I'm telling you the truth. And I can tell you it's not fake because I can see it physically in front of me. And this isn't the same as the flu. When I first heard about it and I was hearing, oh, there's this thing in China, I bought into it. I heard, oh, it's killing off the elderly, sick population. It's a flu. And my friends were messaging me saying, should we be worried about this? And I was like, it's a flu. People get the flu. Some people die, some people don't. This is not the flu. And I just want to stress that the actions we are taking, never before do I think is it more clear how interdependent we all are, how connected we all are, how actions I take here could affect people in a different country. And so I'm responsible for everyone. That's how I feel. And equally, the people that feel like they're not doing anything, you are. Because if you are staying at home and isolating yourself, you are taking an action that is potentially saving lives. And I don't want to ever make that feel like it's not important, because there's so much information out there and it's easy to get overwhelmed. I don't want to listen to it anymore. All I do now is I basically practice surrender. I'm a big fan of the word surrender. I surrender to what is, and I am relying very heavily on my spiritual beliefs and going, whatever will happen, will happen. I can only do the best I can. I can only believe that I hope I'm adequately trained to help as many people as possible. And that's where I'm coming from, is that I believe whatever happens will be the way it was meant to happen, and I will do the best I can. And that's how I'm focusing. But people are constantly asking me, when will this be over? I don't know. My life stopped the minute it hit. I'd really like to get back to the life I'd planned and created beforehand. I don't know when it's over. And all I do now is I take it one shift at a time. And that's all I can do. So I know everyone's looking for that certainty, and I'm lucky actually. In my 6 human needs, uncertainty was always quite high up for me. So, but I wasn't quite looking for this level of uncertainty where I can't plan my life in any way beyond this week. So all I'm trying to say is, please be responsible. Please know your actions. Everybody is connected, and everything you do matters. And I appreciate anyone that stays at home because it reduces my workload. Thank you.
Thank you. So I've got I'm scrolling through catching questions and then I make sure I didn't miss anything. And then I would love if you guys, I know you guys both do some amazing work, and in addition to saving people's lives all day long, I know, and Mel, what you're doing in ICU, I know you do some great work with women, and there's Stephen, you're doing a lot of work with, in addition to being a physician, you're also coaching physicians quite a bit, and I'd love you guys just to tell a little bit about what you guys do. But let me scroll through questions, see if I missed anything. I've got questions. Any thoughts on chloronique? Am I pronouncing that chloronique?
Chloroquine?
Chloroquine?
Chloroquine.
Right, okay. As a treatment, what is that? So I don't even know, never heard of it. What is it? Any thoughts on that treatment?
Hydroxychloroquine. There's been a lot in the media about hydroxychloroquine. It's a medication that's been used to treat malaria for quite a while.
Oh.
It's quite effective. It's generic, so there's a stockpile of it. And the questions out there are, is it effective for COVID-19 or not? I have not seen anything that is a definitive study that I'll just say is very well done that makes me confident that we should be using it en masse. There are certainly some risks with hydroxychloroquine. It can do something called prolonged QT syndrome with your heart electrical patterns. So there is a downside to it, particularly if it's not used appropriately or people aren't screened for that risk. That said, I also have not seen anything that is strongly against trying this out. So there are many studies right now that are going on with it. There's been a lot of, like you mentioned, Mel, anecdotal studies. You know, I think one that comes to mind was a physician who states that he used it on 700 patients and nobody died. You've got to go look into the dirt's always in the details on things like this. So as with everything, it's something to be open-minded about. It's not a proven treatment yet.
Yeah, so we don't use hydroxychloroquine as part of the treatment here in the UK. The reason is because, as far as we know, there isn't the evidence as yet to support it. And a lot of the patients actually, I'm not sure if this was mentioned earlier, a lot of the patients aren't actually all dying from the respiratory. So although primarily this disease, you end up on a ventilator because of the poor oxygen levels in your blood, there are a proportion of patients that are actually recovering from that lung condition, and then they're dying from heart complications. So there is this concern that they're getting something what's called viral myocarditis, which is where potentially the virus is infecting the heart and the heart muscle. So anything that you take that can then potentially add to that insult to the heart could make you more at risk of having cardiac arrest and death. And a lot of patients are dying from cardiac arrest, cardiac problems and death. So we are very cautious about giving a drug that we know has an impact on the heart, which is why it's not being used as a routine for the very critically sick. I have some suspicion that some people might be using hydroxychloroquine in the community. And there is a suggestion it might shorten the duration of the illness and some of the severity of it, but there just isn't the robust evidence to support that as yet.
Thanks. I think there's lots and lots of people thanking you guys for all your wisdom, and especially for being on the front lines. I mean, we look at what the medical community, healthcare community has become the new heroes of the world, you know, and watching what you guys do just to put yourself on the line while the rest of us are lucky enough to sit at home and drink wine all day. So we're very much appreciative for that. The only other question I see in here, and I guess any thoughts on people who are concerned that the COVID deaths are actually overstated? I guess it says because they read the CDC guidelines. So I guess that question means people are attributing things to COVID and it might not really be. But it sounds like from what you said, Mel, the sense is that now to really get counted as a COVID test, you have to pass the test, and odds are there's probably more people that really die from the COVID that got a false negative on the test, so it may be understated. What are you?
It's a complicated picture because, as I said, the numbers that are being stated for us is anyone that's had a positive COVID test and then dies. But potentially, what I could say to you is the COVID might not actually be killing them. It could be that they incidentally have a minor case of COVID and have tested positive, but on top of that, they might have something else like cancer. So it might be a cancer patient that was potentially dying from their cancer, and then they got COVID on top of that. So then on your death certificate, how it works in the UK anyways, you would have mentioned COVID. So that would have been added to the numbers, but that might not have been what actually killed you. So simultaneously, you could have come in with heart problems and had a mild case of COVID, but if you've got COVID and confirmed COVID and you die, that's going to be on your death certificate. So there may be a suggestion, but what I'm saying to you is there's a whole lot of people dying in nursing homes, dying at home, who didn't get a COVID test and are potentially COVID patients, or maybe they're dying of the heart attacks and the strokes because they're not coming into hospital, that are secondary effects of the disease, but are not being numbered. So if anything, we suspect we're underestimating rather than overstating how many COVID deaths we have.
Okay. And are you hearing anything of patients? There's a question on patients getting delirium after coming off the ventilators, or are you hearing any of that? Or?
Absolutely. I mean, that's a common side effect from anybody who ends up on a ventilator on all the sedative drugs, particularly if you're in for 7 to 10 days. So you can have bear in mind, we're just doing alive or dead. Do you survive? Do you get out of intensive care? We're not talking about that prolonged rehabilitation they're going to need afterwards, where they could have significant lung damage. They could have some underlying heart issues. We know a lot of people are ending up with lots of kidney problems post COVID, and they're needing quite prolonged periods to recover. So delirium, kidney problems, heart problems, breathing problems. So there will be a whole population of people who have recovered but still have quite significant after effects, potentially long term.
Anything you could do for delirium, or what are any treatments for that we know of?
I mean, we've studied delirium in the ICU for a long time. We know it's worse with things like age. If you're elderly, you're far more likely to get delirium. I don't know that there's any per se, except trying to give people a proper day-night rhythm and try and get them to get into a sort of natural sleep pattern, because some of it is, when you're on a ventilator, you're in an induced coma. It's not proper sleep. It's a drug-induced coma. So they're actually sleep deprived. So they actually just need sleep. They need a quiet environment where, there's not lots of machines and noise and distraction. And it's just letting the drugs come out of your system, really. So there's no magic pill for delirium.
Again, I'd love to know. Yes, Stephen, go ahead.
I agree completely, and that's I defer somewhat to Mel because that's more your area of expertise. I'll add that always step one is remove the insulting problem, which is they're on the ventilator in the first place. So you've got oxygen at high levels and things called free radicals and all these inflammation processes happening in the brain, which leads to that delirium. So number one is get rid of that insulting thing or process, and then as someone gets out of the hospital and goes back to home, hopefully home, or wherever their new living situation is going to be, that's when I start to suggest looking outside of regular Western medicine that I've been trained in, because there's a lot of ways to support brain health in general. And this is not something that I learned in medical school or residency, but there's a lot of science behind it also. So you go into various supplementation protocols. Rest is huge, like you said, Mel. Especially when it's like when you come off of a concussion, there's an injury to your brain from that concussion from a trauma to the brain. And it's very similar advice: is rest your brain and give it the resources it needs. And some of those things are maybe not the typical things. So John, reach out to me and I can give you some other angles on that offline.
Thank you. So Mel, tell me about the Goddess Sanctuary. Tell everybody here about what you do and what your passion is, and in addition to saving lives every day.
So my passion outside of medicine is feminine energy work. So I do feminine energy coaching and women's circles. I am obviously now trying to transition to an online format because I much prefer to do in-person experiential work. And a lot of it is it's that feminine energy, it's that intuition. It's not purely for women. All I can say is men have feminine energy and do need some some people are disconnected from their feminine energy and it would benefit them. So anybody that's kind of interested in the feminine energy stuff, it's quite new. I started something called the Goddess Sanctuary, and it's basically a safe space to discuss all things feminine. So that's my spare gig.
Stephen, you've just got a great perspective. You know, I work predominantly with physicians. However, I'm not a physician, so you're a physician helping physicians and out there with a great perspective. Share with us a little bit about what you do.
Yeah, it's, you know, it started, my 3-sentence backstory was I was started as an ER physician and then thrown to lead an ER department. Realized how little I knew at that point. So what do you do when you're burned out? You decide to go and get a MBA while you're still working full time. So between doing that and then realizing there was more questions, more problems, I went to get that public health degree. And through doing all that, stumbled into coaching, the world of coaching and personal development. So in leading my teams over the years, I realized just how powerful it is to have a coach as a physician and particularly as a leader of other physicians. And so that's what I really do most of the time now is work with other physicians who either have been recently promoted to a new position, either regionally or medical director at their hospital, sometimes chief medical officer, other physicians who are going through their own burnout, or others who are going through a career change or starting a new entrepreneurial venture. It's that process of coaching that really helped me develop that inner wisdom to realize we have a lot more control over us than we were conditioned to believe. And when physicians can learn that for themselves, they can then pass the baton on to their patients, because the stress is probably the best thing that I love doing for physicians. Is people come to me and we do an inventory and we see most of their center of gravity is frustrated or angry, pissed off, you know, it goes on and on. It's rather negative. And in a few weeks of working with someone, they go and realize that they can choose how they want to feel that day. And then over time, readjust and rewire their nervous system so that they can be the true leaders that they were initially called to be when they went into medicine. So that's what we do at Clinician Coaching Institute. So I'm personally coaching people and also inspiring others, physicians, to become coaches, to keep this exponential growth going in hopefully what will be wisdom for the healthcare professionals.
Thank you guys. I mean, you guys, appreciate both your time. You guys are working like crazy and gave us a generous amount of time. So thank you so much for that. Thank you for your wisdom. Thank you for your smiles. Thank you for being there across the world from each other. Miss Melissa, anything else we need to do?
Yeah, we just want to let everybody know that, you know, we're from Konfidently. We're a company we're an international company. We're a multilingual team of expert facilitators. We've got consultants in our teams. We have these 3 amazing people that obviously have a huge amount to offer. And you can follow us on, you know, on social media. How we spell it, I'm just putting it in the notes right now. It's Konfidently, spelled correctly, but it's got a K in the front. And we're going to start doing more and more webinars just like this, so that people can continue to learn from us. And our objective is to help businesses grow, especially during a time like this.
Thank you, ma'am.
Yeah.
Thank you, everybody.
Thank you.
Thanks for all the participants.
Mel and Stephen, thank you so much. It was so awesome. Thank you very, very much.
Thank you.
Thank you guys. You guys rock.
You're welcome. Thank you all.
You are superheroes. Thank you.
Thank you so much, Mel. Thank you, Steve.
Thank you so much. Bye.
All right,
You
enjoy
guys
the
are
weekend,
awesome.
everyone.
Thank you, Stephen. Thank you, Mel.
Thank you.